or treat illness. Medication-related harm constitutes the greatest proportion of the total preventable harm due to unsafe care. Medication errors occur when weak medication systems and human factors such as fatigue, poor environmental conditions, or staff shortages affect the safety of the medication use processes. This can result in severe patient harm, disability, and even death. It is in this context that medication safety has been selected as the theme for the World Patient Safety Day 2022 with the slogan, Medication Without Harm. Apollo Hospitals has been conducting knowledge series on medication safety since last few days. There has been a series of webinars on various aspects of medication safety by our eminent speakers and sharing of number of medication safety solutions and practices. We discussed and learned newer perspectives to medication safety systems, hands-on approach to safety of high-alert medications, opportunities and challenges, a panel discussion on medication supply chain excellence. In line with WHO campaign, we also took up the medication safety pledge. We have over 5,000 pledges by our healthcare professionals and over 3,000 pledges by our patients and counting more across the group. So not only our staff members, but also our patients are sensitized about the safe use of medications so that there are no unintended harm associated with its administration. In that lieu, we had a very interesting role play session by our Apollo Kolkata team yesterday in one of our knowledge series. World Patient Safety Day is celebrated on 17 September each year, and it brings a proud moment for all of us. To commemorate the week's activities, today on World Patient Safety Day, we have organized this specially featured webinar on managing medication safely, a patient safety essential. I again welcome all the participants to this webinar. May I now invite Mr. Gaurav Loria, Chief Quality Officer and Group Head Operations, Vice President, Apollo Hospitals, for his opening remarks on this webinar. Mr. Gaurav has over 20 years of experience in quality assurance and has been heading quality and operations in Apollo Hospitals. Over to you, sir.
Thank you, Bhumika. A very good evening to you all. As we all know that, medication safety has been one of the most critical components of providing healthcare to our patients. And on this World Patient Safety Day today, and for the last 1 week, we have really been talking a lot about medication safety aspects, which are very important. A quick brief. I'm sure most of you are aware of the, some of the key data points that emergency becomes the third most common source where medication errors happen. Moving from emergency, if a patient is hospitalized, the statistics show that 1 in 30 hospital admissions are because of an adverse drug event. And the average hospitalized patient experiences at least 1 medication error per day. And this could also be either the near miss errors, this could be the missed doses, but these are all medication errors at the end of the day. 30% of patients have at least 1 medication discrepancy in discharge summaries, and these also do happen. While 24 to 23% of these, 25% of the post-discharge errors are actually preventable. Adverse drug events account for more than 3.5 million physician office visits, and 1 million emergency department visits, and 1.25 thousand hospital admissions yearly. This actually results in a lot of economic impact. It's about billions of dollars annually. And the global cost of medication error is almost 1% of the total global health expenditure. And a lot of these errors and the money that is spent on it can actually be saved, obviously also ensuring that the lives are saved if we take care of these processes and systems in our hospitals. Moving to just give you a quick brief on what we as Apollo Hospitals did in the last 1 week. We did take up pledges for the doctors, staff, as well as for the patients, and there were multiple pledges which were taken up by the staff as well as by our patients and their family members. There were medication safety booths for education, which were installed in all the hospitals and the healthcare centers, wherein our team spoke about medication safety in a layman's language to all our patients and attendants. We also did a lot of patient and staff engagement activities as a part of this particular initiative. Some of the hospitals we also were lit with orange lights around the theme of medication without harm. There were multiple training quiz competitions for all the multidisciplinary teams, which were also conducted in hospitals. Going forward, I think one of the important thing is to start using machine learning on predicting medication errors, which we have been working on for quite some time now, to identify, streamline the workflows, remove the duplications, and prevent errors actually reaching the patient. Physician order entry system is another area which I think all of us should be looking at to make sure that there is a higher level of accuracy in the medication orders, and there are no transcriptions which are done by a second level person. Obviously, a lot of technology has come in today, whether it is about pharmacy robots or pneumatic chutes or a better mechanism of transcribing or even delivering medications. We have to look at these automated medication dispensing systems. Obviously, they incur a certain cost, but we can always look at it, what we can do to improve medication safety going forward. But I think what is more important at the end of the day is, when we reach a stage wherein, patients start asking, or every patient who comes to our hospitals start asking before administering, what is this medication that I'm giving for? Why am I given this medication, and what will it help me to do? So that level of awareness, we have been trying our best, but I think it's support from everybody's end that we need to really work towards and make sure that we reach that stage to have a medication safe ecosystem in a healthcare world rather. Thank you so much once again, and a very happy Patients Day to Safety Day to each one of you. Thank you.
Thank you, Gaurav sir, for showing us the key data points and the alarming reality of medication errors, and also talking about the way forward to medication safety. Thank you. May I now invite Dr. Anupam Sibal sir, the Group Medical Director, Apollo Hospitals. Sir has been a very strong advocate for patient safety across the Apollo Group. Over to you, Dr. Sibal sir.
Good afternoon, friends. Thank you, Bhumika. Thank you, Gaurav, Dr. Ziauddin, Preet, Sanjay, Sanjeev, Sneha, colleagues across the Apollo system and outside for participating in this important event. Medication safety became a very significant priority way back in 1975, and significant progress has taken place in the field in the last 47 years. At the second Global Ministerial Patient Safety Summit in Bonn in 2017, the third WHO Global Patient Safety Challenge, Medication Without Harm, was announced with the aim to reduce severe avoidable medication-related harm by 50% in the next 5 years. And those 5 years are up this year. There isn't a doctor or a nurse who can claim that she or he has not been responsible for a medication error. In fact, it would never be a single error. It would be multiple errors that we would have been a part of over the years that we've been working as clinicians. If one is lucky, the error is minor, but sometimes it can be serious. Why does this have to be the case? We all need to recognize the danger medication can pose and work together to mitigate risks. In keeping with the World Patient Safety Day theme of medication without harm, we have an exciting session today. We will learn about what's new, what clinical adverse incidents can teach us, the importance of a pharmacovigilance program, and the 10 commandments for medication without harm. I'm sure the program will make us wiser and motivate us to do more. Thank you so much.
Thank you, sir. On the World Patient Safety Day, patients, caregivers, doctors, healthcare workers, healthcare leaders, and health advocates participates in different events with the aim of raising awareness about the importance of patient-centric care to encourage patient safety on global level. We are proud to showcase our engagement and commitment towards patient safety through a video. Let's have a look. Video, please.
Volume, please. Rinki, can you check on the volume, please?
Thank you for the video. Indeed, safety is everyone's responsibility and it's a teamwork. So let's begin with today's webinar. Today we have with us Dr. Mohammad Ziauddin, the consultant pharmacologist, Telangana Cluster, Apollo Hospitals, and he would be discussing about the newer developments, advances, learning from other organizations. Over to you, Dr. Zia.
Thank you very much. Very good afternoon, everybody. And the topic which I will be talking about of newer developments and advances learning from other organizations. The overview of my presentation, I'll be looking into the current process of adapting current process of medication management in the hospitals and opportunities where all we can have an improvement and adopting newer methodologies and technologies and reporting and analysis of medication errors and incidents, forecasting the trend in medication errors and implementing strategies accordingly, learning from other organizations like NHS, MHRA, England model for feedback and learning, newer concepts in administrations, preparing, dispensing, research and innovation in medication delivery, and patient education and monitoring. So if we see the outpatient process of medication management, the patients who are of health concern, they visit the doctor, they see the doctor, and the doctor review the patient, diagnose for a condition, and prescribe the treatment. When he prescribes the treatment, he explains the medicines, pros, cons of the medicines, educate the patient on medicines and disease management, share the decision-making on choice of medicines. What personalization can be done at this particular stage is the remote consultations, which is well known to all of us in the form of telemedicine, computerized history taking, computerized decision support, informing sharing through technologies. The patient, after seeing the doctor, visits the medicine pharmacy where the medication dispensed, and the pharmacy who checks the dosage, accuracy of the prescription, check for any drug interaction, explain and educate the patients on medication management. At this level, what we can improve is on having more of e-electronic prescriptions and online refill requests, reminders to the patient, and home delivery of medications, educating the patients with the use of electronic tools and medical education applications, which are available on the websites, and medicine management in daily life, like patients should learn about the required medicine, uses, interactions, side effects, refill, dosage, storage, builds medicine taking into new routines like planned schedules, get reminder, change of behavior, and provider monitors the patients and reminders in data collection. So advice seeking via phone and decision support through electronic devices, information acquisition through technologies, and remote monitoring of disease, thereby improving the adherence of the patient to the medication treatment. It's a fine balance that needs to be established between the evidence-based integration of technologies and constructive experimentation that could be a game-changing breakthrough. So how can we use this artificial intelligence in terms of medication safety? Need to understand what is artificial intelligence. Most of us already know it's something which is machine learning, based on the machine learning prediction and the computer gives an options and corrects it. How can we use in cases of medication prescription? The most important thing what we need is the electronic data entry, not the handwritten prescription. The data, the prescriptions, the history taking, the medical history, reconciliation, everything goes online electronic data mode. And the data, what is collected in a standard format, and a tool which can analyze and interpret and give us the data. So when we see the data which comes into the system, which is a first step, there is unstructured data which comes, which requires a standardization into an algorithm of artificial intelligence, and that structured format data which goes into the machine learning tools and gives us an interpretation in terms of the trend, the sector, the graphs, and then the categories where it's required to be improved. Thereby, this definitely helps the patient at the time of prescription, which it gives the alerts or flags when there is a dosage error at the prescription because of any lab abnormalities. or it could be a simple drug-drug interactions which could have happened at the time of the prescription, or a miss or a discrepancy in the medication, a reconciliation which could have happened. So this is the processing which converts the unstructured text to machine readable structured data, which can then be analyzed by machine learning algorithms. So let us see what we can do with this amount of data. For example, if we are having a lot of data from the medication errors, then the the tools, there are quality tools which can help us understand the trend of this medication error in our hospital. The main thing, the basic step which is required is the data need to be broken into minute fine details into the system and to be fed into the system, which then can analyze and give us a trend of what would be there in the coming next years, based on the past 5 years or 10 years of data, which is put up into the machine learning tool and gives us a prediction or a forecast of how we are going to have errors in the next 1 year in the different months and the different season, and what could be the contributing factors and how it can be prevented, and thereby help us to implement strategies to prevent the expected errors which can happen, maybe because of a seasonal trend, where is a new recruitment happens for a particular one reason for a particular staff which happens. So the induction training, those things can be boosted, such an example, how it can implement the strategies to prevent the medication errors happening. So reporting incidents and medication errors, does it happen, how it happened, and if it is happening, whether is it an anonymous reporting or the hospital, the organization support the staff in having a safety culture and reporting to be more transparent and encourage reporting among the staff. So there are many tools which can be used, such as web-based reporting tools, which hospital or organization develops, which helps the staff or the patient who can log in or use the URL and report anonymously without any kind of a credentials, and report the incidents or medication error into system, which can help us then finally to analyze and understand what went wrong, where went wrong, and what has happened, and how to correct these things. When we look into such kind of data in terms of medication error, the numbers when it is very high, so how do we focus on implementing the preventive strategies? So this can be used in terms of quality tools like a Paretographs, where we can focus on the low-hanging causes which we can address, and immediately that can bring down significant number of errors into our system. So learning from other organizations such as NHS, which has the very good flow algorithms, when it goes, the errors goes into the portal, and then the NHS England analyze it, MHRA, and then onto the National Medication Safety Network, which gives a feedback and how to minimize the risk, and it gives the feedback to the healthcare professional and the medication safety officers, which in turns monitors and have a check on the drug safety updates and implements those preventive strategies into the organization, and thereby making more robust medication safety system in the hospitals. So let's see what are the newer concepts in medication administration. Electronic medication administration, EMR, which is a main play a main role which it plays by the IT, where the medication administration, not only on the documentation, it happens through electronic system as well, side by parallelly, which ensures that the patient who is receiving the medication is the right patient at the right time, right dose, and the right medication, by verifying the credentials of the patient with the electronic medical record, and allowing the nurse to ensure the administration of medication happens. Also to monitor, is there any kind of a delay in administration of medication, or to send signals or alerts or messages to the staff in case the due time for medication has crossed and the medication is getting delayed. So let's see what else we know. We know there are pumps, infusion pumps, which can be given through the infusion can be given through the pump. There are smart pumps. Now there is smart pumps movement from smart pumps to the intelligent infusion systems, which incorporates a wireless device, which can also build into the software interface and link the patient prescription to the drug information and gives an alert to the prescriber or the administrating nurse on how the dose is monitored. Is there any drug interactions where need to be checked? And uniquely, it's a bidirectional information transfer which can happen both from and to the pump. There are advanced pumps which also get integrated with the patient vitals and alert the staff when the patient is having any kind of adverse drug reaction due to derangement in the vitals. So newer concepts in dispensing and preparation, newer concepts in dispensing, we now come across many terminology like robotic dispensing of medications and many other things. There is one very useful thing which a lot of other organizations adopted, like automated dispensing machines. What are these? These are those units which can be used as centralized as well as decentralized to the ward or location, ICU locations, to the staff nurse who is using it, and thereby helps the patient to thereby help the staff not to have any kind of a delay and prevent error from happening and wrong dispensing or wrong patient dose or a wrong drug. When it comes to preparation, there are a lot of preparation which happens by the staff nurses in the clinically in the ward areas. Since 1970, there is a shift of the preparation of the medications goes more towards the pharmacy, the pharmacist who does the compounding preparation. This is more into practical in terms when we come across the chemotherapy medications, because the chemotherapy medications involves risk, cytotoxic risk, and as well as errors which can happen. There are systems which are automated chemotherapy admixing units, which ensure the manual errors are omitted in this case. So maintaining the cold chain is a challenge when it comes to a supply chain of medication, where the medication is from the manufacturer and through the cargoes, and it comes to the patient. What we can ensure is having a simple data logger, which can track the temperature during the cold chain transport and during the transit, and give us the data. How is the efficacy of the medication? Is it maintained or not during the transit? As well as when the medications are stored in a walk-in cold room, and there is installation of the walk-in cold room alarms or the monitor, which gives alerts via email or SMS or WhatsApp to the designated number and email ID when the temperature goes beyond the manufacturer recommendation, which allows us to have a time and ensure the medications are not affected during the storage time. So medicines with the barcode or QR code, you must be aware or having come across during the news that there are a lot of discussion on having a barcode or a QR code on each medications. Yes, it is right. The medication, the government of India also is coming through draft rule. They have come with a draft rule which says about having the QR code or the barcode with the manufacturing products. It's going to be mandated to the pharmaceutical industries, where every drug will have a barcode and QR code. Definitely, this will help the hospital who are having an electronic medical record to scan that particular drug and to ensure the supply chain and to prevent spurious substandard drugs coming from the supply chain. The trials and research which is happening in terms of medication delivery, there was a trial which was done from medicine from Sky Trials, which was done in collaboration from the World Economic Forum and Apollo Health, Niti Aayog, where the medications were checked how it can be transferred with the help of a drone, particularly the vaccines and emergency life-saving medication to the remote location in our country. So the trials is underway. Most soon we may have this as a reality in our setups. There is also a discussion about the RFID, which comes along the vial. What is this RFID? It helps the pharmacy to have a track of each vial and the medication with their batch number and expiry, especially those medications which are anesthetics and which are also stored in the crash carts and kits, and it is stored in across the hospital, and which are prone for having a human error because of expiry date or an incorrect batch number or a recall of a batch number. Patient education and self-monitoring, definitely more newer developments are there, where the for patient education pamphlets is more of an educational e-file which is shared on patient phone. And there is also, like we all know that glucometer there is required a prick and to be checked. There are devices which also come with a Bluetooth sensor and the reader, which enables the patient to maintain the glucose across the number of days, and helps the insulin dosage, how to prescribe based on the mean glucose reading of the patient and prevent hypoglycemias. Also, WHO has launched a WHO MedSafe app, which you can scan the displayed QR code and go to the Google Play Store, download this. And this is for the healthcare givers as well as for the patients to know what questions they need to ask with their healthcare professionals. So last but not the least, they are the WHO Global Patient Safety Challenge, which already mentioned, medication without harm. The theme for the World Patient Safety is the medication safety without harm. Thank you.
Thank you, Dr. Zia, for that detailed insight on the current processes that the healthcare organizations are following, discussing about the newer concepts in medication administration, dispensing, preparation, the artificial intelligence that can be implemented in medication safety. And certainly these newer concepts and systems would help healthcare organizations throughout the world in medication safety, and hence enhancing further the quality and patient safety. Thank you, Dr. Zia, once again. Our next speaker for the day is Dr. Sushil Jain. Dr. Sushil did his medical graduation in 1995 and PG tenure in surgery in 2001. He shifted back to Indore and was associated with different hospitals in Indore. Dr. Sushil joined Apollo Indore in 2013 as a part of cardiac surgery team. He headed the emergency for a short duration, and in 2017, he was assigned additional administrative role, and currently he is the medical superintendent of Apollo Rajshri Hospitals, Indore. May I request Dr. Sushil Jain to take us through the learnings from clinical adverse incidents. Over to you, Dr. Jain.
Thank you, Bhumika, for the introduction, and really appreciate the talk Dr. Ziauddin has given the insight over the latest technological development which are occurring in the field of patient safety. So I'll just share my screen and like you to confirm whether it's visible or not.
It is visible, sir.
Is it all right?
Yes, sir.
Am I audible, Dr. Bhumika?
Yes, sir. You may proceed.
So, I'll restrict my talk to some clinical learnings which we have observed in our unit and other units out of the Apollo also during my clinical practice, and I'll restrict my talk to those clinical scenarios. So when we come to learning, there are few important things which we have to understand. One, learning never ends. Two, everyone is a teacher and I'm always a student. I remember my initial days during medical graduation where I've been taught many things by the nursing staff. And I still remember putting in my first endotracheal tube, which was guided by a senior ICU staff. I'll always be a student and everyone else will be a teacher for me. There are two ways of learning. Learn from others' mistake, or commit mistakes, pay for it, and then learn. Unfortunately, in our scenario, who is paying for the mistakes? Patient who pays. So we cannot waste that, and we have to take all the opportunities to learn and to avoid mistakes, because we do not have any authority to let this pay go waste. So with this, I'll start with few clinical scenarios. I'd like to skip this slide because we have been talking about what is medication error and all those things. So I'd like to skip that slide. I'll straight away come to only a few cases, 4 or 5 cases, which are the clinical scenarios we have actually observed at various places. So coming to the case number 1, this was a 12-year-old child who reports to ER and is diagnosed to have a diabetic ketoacidosis. He was under treatment for seizure disorders and had no history of diabetes in himself, or there was no family history of diabetes in any of the family members. It was real surprise that he's suddenly reporting to the ER with diabetic ketoacidosis. So we went for the prescription review, and we found out that he was on prednisolone, that is a steroid, for since last 4 months. We talked to the neurologist and tried to find out why was prednisolone prescribed to this child, but he denied remembering any indication of giving prednisolone. So we faced the older records. To our surprise, actually it was the child was prescribed primidone, which was because of the illegible handwriting of the physician, was read as prednisolone, and prednisolone has been continued till last 4 months, and the child lands up into a diabetic ketoacidosis, otherwise a healthy child. And to his luck, even when primidone was not given, he didn't show any seizures in the last 4 months. So that was his luck. So what is the learning? We have to give attention to sequence of events which has happened. It's not that at the point of moment this is what has happened and we have to do this. Number 2, the importance of root cause analysis. If we have just shrugged it off that okay, it was because of steroid, the condition was because of steroid-induced diabetes, we would have probably not gone into the root cause of illegible handwriting and the sequence of events. So that also highlights the importance of a legible handwriting, which fortunately at Apollo, since we are practicing the e-prescriptions, so the errors of illegible handwriting, at least in the OPD, are gone, and soon we will be launching with the IPD systems also. So that is something which will be taken care of. Next is the prescription review. So had this prescription been reviewed by the pharmacologist before discharge, probably this mistake would have been avoided. Coming to case number 2, this was a post-CABG patient who comes to emergency in cardiac failure. The ECG shows raised elevated ST segments. He was discharged just a day earlier with advice of injection Clexane 0.6 ml subcutaneous BD on discharge. However, the discharge summary said Clexane 20 mg subcutaneous BD instead of 60 mg. This was a transcription error which has occurred. So what is the learning? When we are advancing with the advanced technology in preventing the medication errors using the systems, one thing which we have to be very careful is while selecting from the top-down list. So all the Clexanes, all these strengths will be listed together. And it's very easy to commit a mistake to select one which was above or below that intended medicine. So this is something which we have, this was a learning from that error. We have to be very careful while selecting the medicines from the drop-down. Recently, we had a case where a cuticule was indented from the operation theater. And instead of selecting a smaller size, 10 by 10 centimeters or 10 by 30 centimeters were indented. It was just a small surgery. It was all of it was wasted because it cannot be used in any other patient. Coming to next case, this patient had hypoglycemia while admitted in the hospital. A medical emergency team was called. We found that injection human extrapolate insulin was given instead of Besaglar, which is a long-acting insulin. The small error, just the error of the selection of the insulin, and the patient landed up into this trouble and was having hypoglycemia, and a med team was called. One patient of on tablet, I'm sorry for this spelling, tablet doxycycline 100 mg BD develops redness and itching over the palms and continues to have fever, for which he was admitted initially. While the patient is being worked up for the fever, cause of fever, another antibiotic is added to the prescription, thinking that this rash is due to the fever and not due to anything else. Patient develops oral ulcers on day 3. Actually, the patient was allergic to doxycycline and he did not report it to the treating physician. There was no way to find out that the rashes were actually due to the allergy to tablet doxycycline. Not only the patient did not report the previous known allergy, but physician also missed the initial signs of allergy and did not stop the culprit medicine for 3 days and instead added another antibiotic, which was again irrational. So the learning is we should ask for the drug allergy history very specifically. At times, people do not give enough importance to this history that, okay, that might have happened because of some medicine and it has gone. But then we have to specifically ask and elucidate the history of allergy from the patients. And number 2 is, of course, paying attention to all the symptoms which are occurring. A simple look back into the case would let us to diagnose to the inference that it was actually an doxy allergy and it could have been stopped immediately. Case number 5, a patient post-CABG in recovery suddenly had a ventricular tachycardia after an injection. Obviously, the nurse was asked that what is the injection you have given. She denies everything except the prescription medicines. Immediate CPR was started, which was not generating enough pressures. Patient had landed up into complications of acute kidney injury, had ischemic neurological damage, and finally, after a long struggle, we couldn't save the patient. So, actually, when we detailed, which was suspected, injection of potassium chloride was administered as IV bolus. Actually, he was prescribed a sedation because he was fighting with the ventilator, and sedation was to be given, but instead potassium chloride was given. And we found it out by when we explored the dustbin, we emptied the dustbin, the ampule was found in the dustbin. This happened in another hospital. I would not like to name that, but this was what the root cause was. So the learning, of course, it exemplifies the importance of high medication alerts and how they are to be handled. We have the definite protocols for storage, administration, cross-checking of high alert medication. The simple mistake, just because the ampules were looking same and she did not cross-check the drug before giving, the patient was actually lost. So what are the learnings from these cases? Legible prescription is a must because it can lead to misunderstanding by the pharmacist or by the nurse, and then lead to unnecessary avoidable complications. All the details are to be included. We have to ensure an accurate drug history, specifically emphasizing on history of allergy and any previous drug which the patient is taking, which can cause a drug-drug interaction with the existing treatment. We have to ensure that we have a proper knowledge of the drug which are being prescribed. All the administration errors, the root cause analysis and the CAPA boils down to 7 rights of medication. If these 7 rights of medications are followed verbatim in each and every dosage administered, I don't think there will be any administration error whatsoever. So it's very simple. You just keep the orders, the drug, beside the patient, and just before the administering, cross-check it with the notes, and you will avoid any error happening in the administration. We have to follow the prescription guidelines, follow the rights of medication, update our knowledge about the medications. We should not guess that, okay, this might have been written. We should seek clarification rather than guessing. And we should minimize interruptions while giving prescriptions. So a sister is administering some drug and she's called on for something else. Obviously, there will be interruption and there might be higher chances of errors. Dosage calculations have to be very perfect, and if you have any doubt about calculation of dosage, we should always look forward to our seniors, or we have the apps which can easily calculate the dosage for us. We should have prescription, drug, and the patient at the same location while administering the drug so that they are verified. We should not use any substitute or open medication if they are received from the pharmacy. And we should check medications for expiry and quantity after receipt. With that, I'll end my talk and would like to address any questions which are posed to me. Thank you.
Thank you, Sushil sir, for sharing and discussing those clinical learning. So we learned that any error or any patient event that leads to a learning, and learning helps us to improve further. Thank you, sir. Let's now get practical guidance on pharmacovigilance program from Dr. Sanjeev Sharma. Dr. Sanjeev Sharma is competent and versatile medication management, research, and administration professional with extensive experience of over 17 years in setting and managing multiple functions in Apollo hospitals. Currently, he is working as clinical pharmacologist and pharmacovigilance and materiovigilance center coordinator. He is holding Doctor of Medicine, Pharmacology, and MBBS degrees. He is also Six Sigma Green Belt. He is a member of American College of Clinical Pharmacology and member of Medication Safety Officer Society. He is having 16 publications in reputed journals and 6 book chapters to his credit. May I welcome Dr. Sanjeev Sharma for his presentation.
Thank you, Bhumika, for nice introduction, and thank you, Apollo Hospital, for giving me this opportunity to talk on very, very important topic. Can you see my slides?
Yes, sir.
Thank you so much. Pharmacovigilance, a practical guide. Let us look into this. All of us health care providers, we have always one aim in mind: primum non nocere. First, do no harm. But the medication, what we handle, they have harm not only to the patient. It is an issue for their family. It is an issue for the community. It is an issue for the healthcare. It is an issue for the industry, a public safety issue we deal with, and we all have this responsibility in addressing this issue of toxicity. Let us look into what is pharmacovigilance. It is science and activities for detecting, assessment, understanding, and prevention of adverse effect or any other medicine-related problems. Looking into, let us go back, why we require this, what is the importance of pharmacovigilance. This pharmacovigilance is required for improving patient care and safety in relation to drug uses. We gather and assess more information or new information sometime, so that we can use the product more appropriately. We can look into benefit risk ratio. We can identify the risk and harm associated with the medications, and accordingly we can. We know all these drugs get approval only once phase 1, phase 2, phase 3 clinical trial is done, extensive studies are done. But when this drug comes in real world scenario, we give them to heterogeneous population. People who have multiple diseases, already on multiple medications. There may be drug-drug interactions with these people. There may be unexpected adverse drug reaction. The medicine which was tried in thousands of patients will be tried in crores of people now. We will look into the effect of this medication on quality of life in real world scenario and long-term effect of this medication. That's why it's very important to have a look. We started long back in 1959 and 61. There was a big disaster happening when thalidomide was given to pregnant lady for morning sickness, and 4,000 to 10,000 cases of phocomelia, congenital limb defect happens. This drug was withdrawn, but there was a lot of hue and cry after this drug, and it led to WHO thinking about and starting a pilot project way back in 1963, which continued up to 1968. The purpose of this pilot project was to develop a system which was applicable, and it can be replicated internationally for detecting previously unknown or poorly understood adverse drug effect of these medications. From this pilot project, the current practices and science of pharmacovigilance emerged. Now we have WHO Upasala Monitoring Center at Sweden, very nice place, and now more than 60 member countries are reporting. Let us look into what happens in India, and going back from the history of 1747 of clinical trial. First time James Lind tried lemon juice for preventing scurvy, and 1937 because of syrup of sulfanilamide was prepared, 107 children died because of this. 1950 chloramphenicol induced aplastic anemia was reported. Of course, in 1963 to 59-60 this thalidomide disaster happened, and 63 to 68 that famous WHO project for which led to the pharmacovigilance. Coming back to India in 1996, we started doing a lot of clinical trial of global standards. 1997, India joined as a ADR drug monitoring center by WHO. 1998, pharmacovigilance program was started, and 2002, National Pharmacovigilance Center was established in India. 2004 to 5, National Pharmacovigilance program was launched, and in 2005, we started conducting structured clinical trial, and 2009 to 10, pharmacovigilance program of India started, and we started. There was one time when we were reporting hardly anything and contributing any database of adverse drug reactions. From that time, we have active 311 ADR monitoring center across India. We have government has engaged pharmaceutical industry in reporting. There's an Android app available. There is a research-based pharmacovigilance for optimizing drug safety. There's continuous training being provided. So how this ADR can be reported, who can report it, and whom to report? Healthcare professionals through ADR monitoring center can report to PVPI center, Pharmacovigilance Program of India at Ghaziabad. Consumer either can come to hospital or directly through a toll-free number they can report. Industry can report to Pharmacovigilance Program of India. Looking into few definitions so that we understand it. Adverse event is untoward medical occurrence which may or may not be associated with the drug. Adverse drug reaction is untoward unintended response of medication which is associated with administration of the drug. Unexpected adverse drug reactions are those where nature or severity of this is not consistent what is available in investigator brochure or summary of product characteristic. How to report a side effect? What is minimum standard of report is required? We need to have identifiable reporters, contact detail, so that we can follow it up. Identifiable patient, his patient initials, his sex, age, or group age if exact age is not available. Suspected adverse event, what happened, and suspected medical product if available, batch number or expiry date of that product. Obtain as much as additional information we can get. If not, at least report that one. So this busy slide shows we have a ADR reporting format, and it can be either done through this ADR reporting form, or it can be done through mobile application which is available on the Play Store, and we have a toll-free number which is provided here, and of course we have 311 ADR monitoring center which are reporting. So this busy slide shows that this ADR form, initially there are patient-related information, and then we have a drug-related information where we want what drug, who was the manufacturer, batch number, expiry, dose, route, frequency, when it was started, when it was stopped, when reaction happened, when reaction stopped, and detailed information and causality of this information. What happened when drug was withdrawn, what happened when dose was increased or reduced, dose not changed, and all this information, and concomitant medication, and of course, any additional information. This is provided, and then we look into whether what kind of this ADR, whether it's acute, subacute, or latent, what kind of severity, mild, moderate, or severe. Severe are those which are maybe fatal or life-threatening. Moderate are the one which requires additional antidote or hospitalization. Mild are the one where just discontinuation of therapy is okay. Incidental is very, very mild, nothing is required. This Hardwick severity assessment scale tells us how we can differentiate between mild, moderate, and severe. Level 1 to 7 are there in there. Level 1 is where ADR has happened, no change is required. Level 2 is we need to discontinue the drug. Level 3 is additional antidote is required. Level 4 is transfer to ICU or causing admission in the hospital. Level 5 is transfer to ICU. Level 6 is permanent harm to the patient. Level 7 is death of the patient. So mild 1 is level 1 and 2, moderate is 3, 4, and severe is 5, 6, 7. So what happens, how different centers are connected with each other. We have ADR monitoring center, which report to pharmacovigilance center. There we have signal review panel, core training panel, and quality review panels, and they have advisory committee which keep on advising based on reported adverse drug reaction to the government of India, and this report to various stakeholders for patient, healthcare providers, or pharmaceutical industries, and they keep on guiding them based on that. What happens when we report a side effect? Depending upon the severity of the side effect, following result may happen: updating the prescribing information, dose change, warning to the to confirm demand, batch recall may happen, product discontinuation may happen, change in indication may happen. These are the different things may happen. Let us look into before 2011 we were reporting as a country only 577, and that was the time Apollo also took an initiative. We were the first private hospital to be part of pharmacovigilance program of India, and see, after we started reporting from infancy where we were not doing anything, we became 9th largest reporter of adverse drug reaction to WHO database. And next slide shows what happens with these drugs. Till 2020, 111 drug safety alerts were generated. Out of that, 55 package insert signals came and we could do the changes. 2021, 18 drug safety alert were generated. 4 changes in package insert happens. 22 from Jan to August, 8 safety alert have already been generated and 6 package insert changes have happened. Total 137 drug safety alert and 65 package insert changes have happened, and we are happy that some of this alert we could generate from our system and helping that. Let us take a pledge towards the patient safety, make sure that our doing will always be towards the patient care and good. We will always keep patient at the center of the care, and let us come together and make a promise for better care. Thank you so much.
Thank you, Dr. Sanjeev, for taking us through the pharmacovigilance program, and certainly we all promise for a better care for all of our patients. Moving forward, success is a journey and not a destination. This is reflected in the vast 25 plus years of nurturing, learning, and leading in the humble field of nursing with more than 14 years in senior leadership. I invite our next speaker for the day, Dr.
Video is frozen. Is it at my end or it's?
May I request Dr. Sneha to continue her presentation, please?
Yes, just a minute, sharing the screen. So namaste, good evening, everybody. I take this opportunity to thank Usha ma'am, our group nursing director, for giving me this opportunity to be part of this wonderful session that is on 10 commandments for medication without harm. Going by the history, we all know that whenever there has been a harm, especially with related to medication, it has been the impact has been very high on an economical and psychological burden. And this burden does not happen only to the patient, it is also a liability of the hospital. So moving forward, we need to acknowledge and take a pledge as we had taken, and not take a pledge only on a day when medication safety is being recognized, but a pledge every day when we come to work to see that we work towards the prevention and reduction in errors. Every eminent speakers have spoken many things about the medication management, the newer concepts, the case studies. But I would want to take all of you through, the commandments that we need to follow, so that we can provide and we can promise our patients that that he or she is safe in the hospital environment. So what I feel is when you use your commandments, you cannot simply use your 10 commandments. You need to use your critical thinking. How does this critical thinking happen? When you use your right patient, when you ask about your right patient, the right patient is whether you go and check as a nurse. When I say that I'm a clinical partner to a clinical care, I would have to identify whether my patient is having his ID band with a correct UHID number. I will ask my patient whether he's able to identify himself in his full name, because there have been incidents in the past where a patient with a single name can be repeated and a wrong drug can go to another patient of a same name. Of course, you need to explain to the patient the time and the need for the medications. Now, the right medication, nurses must discuss what are the risks, precautions, and responsibilities before a medication is prepared. Now, is the right medication being given for the right reason? Especially when you give your high-risk medications, you need to have 2 people so that you take the extra precautions to see that the errors doesn't happen. Check the medication label against the prescriptions. It's always a double check. If you have a doubt, you have to take that responsibility to verify with the consultant that I'm in doubt that whether this is the right drug that I'm about to prescribe. Also ask the patient if they have a drug allergy, which I'll be talking into my next slide. The right dose. Do we take that extra step to check what is the prescription? Do we take that extra step to check what is the drug calculation? Know the drug, its expected effects and the side effects. Especially, it is very important that you check the time. You need to clock it. There is a time, there is a prescription order, there is a necessity why the consultant would prescribe the drug in a clocked manner. So as a nurse, we have to see when was the last drug that was given. We need to know the dose, the delivery rate calculation, especially when you use all these pumps or the syringe pumps, the infusion pumps, why it is required that you set it right. Why is it important that you need to know that your dilutions of your concentrated electrolytes go correctly? If it didn't go correctly, it would hamper your patient. Right route. There has been n number of errors where we see eye drops being installed into into the ears, or you see a pessary being taken as a tablet, or intramuscular injection given as a subcute. Many, I can name many. So you need to recheck the prescription of the drug. It is very important that you document, because if you do not document, it is very clearly understood that you haven't given the drug. It's very important that you that you need to know how to do a legible authorization. Many times we see that in the drug chart, the nurse or the doctor would just simply have their initials and we would not know if a cloak number is not written, we would not know whether it is the nurse, and the nurse will not be able to justify in the end of the day or in the end of her shift that she has completed giving the medication to the patient, because your patient is so anxious, your patient is in a different condition. Patient may remember, patient may not remember that he has taken the medicines. Again, to reiterate, in your high-risk medications, definitely 2 nurses must verify and then sign the medication chart. Of course, there is an important to the patient education. The nurse has to observe for any allergic reaction and educate the patient to inform immediately. I also feel that we all are talking about very good things, but what are the things that run in the mind of a patient? So I'm talking, what if I was a patient, what would run in my mind? What is the name of this medication and what is it for? Do we ever take the chance? Do we ever stop? Do we ever pause and explain to him what is this medication for? What is the risk and the possible side effects? And why he has to take it or why she has to take it? Is it appropriate for my treating condition? Have I told my doctor and my nurse that I have an allergy? Many a times you see that sometimes when, especially, for example, if the antibiotics are given and the patient doesn't talk about his allergies, and then you see so many kinds of adverse drug reactions that happen, and sometimes it is fatal in nature that it becomes irreversible. So as a patient, we need to allow him to clear his doubts. Starting a medicine. Again, what is the name of this medicines? The risk and the possible side effects. And as I said, the allergies. Taking my medication. When should I take this medicine? Why are you giving this medicine at this time? He has a right to know. How should I take this medicine? Orally. There are some drugs which you have to take before the meal. There are some drugs which you need to take after the meal. Why is it important? Is there anything that is related which will work out with my food drug interaction? Is a dietitian necessary at this point of time who will also add on to some knowledge to this base? Now, how do I know that I will have a side effect? And should I be careful? Should I panic? When should I press my panic button? Can I refuse a medicine? A patient in the condition staying in a hospital, it's a patient right. He can say that I have not understood the medicine and I don't feel that it is necessary for me to take this medicine. So this is a patient's doubt, which we should be ready to understand and take that responsibility to make him understand. Have I told my doctor or my nurse that I'm also taking a home medication along with the other medicines that he has prescribed? Does this medicine interact? Can I suspect? How do I suspect that I'm beginning to get an allergy? So what could be the symptoms that I'm supposed to look upon? And what should I do? And when should I put when can I put my panic button and call the nurse to attend to me immediately? And am I able to manage multiple medications? I always see that a drug chart would have, not less than say 5 drugs. And it could be 5 drugs, maybe 10. I do not know how many. I do not want to mention that. And sometimes the patient does have that anxiety, so many medications at a time. And how will I manage? So these are the doubts which we as clinical advocates, clinical partners, we need to check and make the patient understand. I would sum this up. Also add these other few points, that we need to create a safety culture in the use of medication management. We need to learn how to understand and report the medication errors. We always shy away in reporting the medication errors. Secondly, what are the failure modes and the effect analysis? We often go halfway and then we would not complete the analysis in order to not to come up with different ways and means how we could have avoided this error. What is the measurement of safety culture? Do we identify any safety issues? Evaluate the patient's safety interventions? Are we part of these regulatory requirements? And if we are part of these regulatory requirements, how it can impact the image of the hospital if we are not careful? What is the role of leadership for a nurse who is at the bedside, who is responsible? Even at the leadership level, we as leaders, have to be responsible for a cultural change and implementation. What is a pharmacy's role? I would not go into the details, but I would just touch point on appropriateness of prescription, maybe transition of care between hospitals, appropriate supply of medications, using the medications. They have to see that the medications are used in the correct way. And definitely they need to watch for the potential harmful medications related problems. If you check to the A, B, C, D, E, A, F, the reconciliations, the logistics, the medication informations to patients, therapeutic monitoring that is required, and the medicines used processes that we use at every time have to be important. My dear colleagues, all that I would say that as a clinical partner, when we have taken the pledge, we need to be very, very careful. We need to reiterate and remind ourselves that a patient who enters into the hospital has entered this hospital with a lot of expectations, an expectation to return back home safely. And it is our responsibility to see that the patient returns back home safely without a medication error. That's all from my side. Thank you so much.
Thank you, ma'am, for giving us insight and emphasis on the critical commandments for medication without harm, and also reiterating the role of leadership, the staff members and patients to ensure medication safety. Now, concluding today's session, may I request Ms. Pritendra Sachdeva, the Regional Quality Head, Northern Region, Apollo Hospitals. Over to you, Preet ma'am.
Thank you, Bhumika, for the introduction. Is my screen visible?
It is, ma'am.
Friends, as we conclude today's session, we need to realize that each one of us is privileged to work in the healthcare. We are empowered because we have the opportunity to serve the community by treating illness and distress of our patients. So, we need to serve this noble cause by caring without harming. And this should be our motto. In the words of William Foster, quality is never an accident. It is always the result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. This quote clearly states that compassion, sincerity, and diligent performance are the qualities that we need to adapt on a daily basis. This helps us to ensure the safety of our patients at all times. With this, I thank you all, and once again handing over to Bhumika for the vote of thanks.
Thank you, ma'am. Now, in conclusion to this session, we would like to extend our gratitude to our beloved chairman, Dr. Pratap C. Reddy, sir, Dr. Preeta Reddy, Ms. Shobna Kamneni, Ms. Sunita Reddy, Dr. Sangeeta Reddy, for supporting patient safety cause and pushing us to do more each day. Thank you for motivating us. We thank our senior management of Apollo Group, Dr. Hari Prasad sir, Dr. Anupam Sibal, Captain Usha Banerjee, Mr. Gaurav Loria, for the leadership and directions which help us to strive our journey towards quality and patient safety. We thank all our speakers connected with us throughout the week, who with their profound knowledge enlightened us with the best practices in medication safety. We thank all our medical and nursing fraternity across the group who are always at the forefront for our patients. We thank the clinical pharmacologists and each and every member of Apollo Pharmacy team who not only ensures timely availability of medicines, but also ensuring all the highest standards being followed in terms of medication safety for our patients. Thanks to all the quality team members to be vigilant enough, supporting various teams in the hospitals, monitoring and evaluating processes for quality and patient safety. We thank all the staff members of Apollo Group who are mindful about the medication safety practices, ensuring patient safety, following policies and procedures to keep our patients safe. Thanking all of our patients who have built trust in us and our hospital processes and systems. A big thanks to Gaurav sir, all the regional quality heads for planning out the entire activity for the World Patient Safety Day and successfully implementing it. Profound thanks to Dr. Nandini and her Marcom team. A special mention to Ms. Rinki Ahuja for helping us for all the branding, creatives, social media support throughout the week. Lastly, thanking all the wonderful audiences who have been actively participating throughout the week. Thank you all once again for joining in today and making it a successful program. Let's be all safe and keep our patients also safe. Thank you. Namaste.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Yeah,
Thank you.